Welcome back to AMC Decoded. We are continuing our High Yield MCQ series today with question number 8. This question is a favorite across the board medical examinations such as AMC, USMLE, and PLAB because it will test a medical emergency where almost correct is not good enough. Let's dive in. Here is the case. A 73-year-old woman presents to the clinic complaining of a severe throbbing headache on the right side of her head that has persisted for 3 days. She reports that her scalp feels incredibly tender, specifically noting that it hurts to brush her hair. Upon further questioning, she mentions getting tired jaws while chewing her steak dinner last night. She also reports a 2-month history of aching stiffness in her shoulder and hips, which is worse in the morning. Now, on physical exam, vitals are normal. The right temporal artery is palpable, thickened, and tender. Visual acuity is 20 by 20 in both eyes, and fundoscopy is normal. Labs. ESR is 85, which is high, and CRP is elevated. Which of the following is the most appropriate next step in the management of this patient? A. Refer immediately for a temporal artery biopsy and await results before treating. B. Initiate a high-dose oral prednisone immediately. C. Order a CT angiogram of head and neck. D. Initiate a low-dose oral prednisone immediately. And E. Prescribe sumatriptan and advise the patient to rest in a dark room. Now, I want you to pause the video right now and lock in your answers. Ready? The correct answer is B. Initiate high-dose oral prednisone immediately. If you picked option D, low-dose prednisone, you fell for the trap. You correctly identified the stiffness as polymyalgia rheumatica, but you missed the critical escalation to arteritis. If you picked option A, biopsy first, you made an error. Let's try to decode it. First, the diagnosis. This is giant cell arteritis, also known as temporal arteritis. You misfought the buzzwords. And the buzzwords are scalp tenderness, the hair brushing sign, and jaw claudication. This is the highest specificity symptom. Tired jaws or jaw claudication in the question equals to GCA. Now about that stiffness. The history of shoulder and hip pain is polymyalgia rheumatica. It is present in 50% of GCA cases. But remember, GCA is a medical emergency because it leads to irreversible blindness. That dictates our treatment speed. Workup and diagnosis. Our lab shows ESR and CRP will be high. An ultrasound, a halo sign will be seen. But the gold standard is temporal artery biopsy. Because of skip lesions, you need a long segment, at least 2 to 3 centimeters. But the rule remains, treat clinically. Do not wait for biopsy. You can biopsy up to 2 weeks later and the pathology will still be there. This slide is the key to the whole question. PMR alone or polymyalgia rheumatica alone. If she only had shoulder and hip stiffness, then low dose steroids would have been the correct option. But she has a headache and jaw pain. She has graduated to GCA or giant cell arteritis. Low dose is not enough to stop the vasculitis. You need high dose steroids. You have to ask, does she have a visual symptom? And why you have to ask it? If there is no visual symptom, then the standard is high dose oral prednisone, like our patient. But if there was any visual symptom, then the answer would have been IV methylprednisolone pulse therapy. Quickly, what counts as a visual symptom? The curtain coming down, the double vision, the blurring of the eyes due to optic nerve ischemia, and permanent loss due to anterior ischemic optic neuropathy. All of this, they are medical emergency, and you need IV steroids immediately for these conditions. Now, long-term risks. For the board, look out for the long-term complication. Giant cell arteritis involves large vessel and can weaken the aorta. Years later, these patients are at risk for thoracic aortic aneurysm, right? So they will need annual screening. Let's review the traps one last time. Option A, biopsy first. Delaying treatment risks permanent blindness. Remember, treat first and biopsy later. Option number C, CT angiogram. This is a technology trap, as I like to call it. It will delay treatment and is in the first line test. Option number D, low dose prednisone. This treats the polymyalgia rheumatica but ignores the giant cell arteritis. You need high dose to save the eye. Option number E, sumatriptan. This is a wrong diagnosis or incorrect diagnosis. A 73-year-old with high ESR and joint pain does not have migraine. She has vasculitis. So, this will be your rapid review takeaway. An old person with headache and jaw claudication equals to GCA until proven otherwise. Never refer to ophthalmology before starting steroids. And the algorithm. Vision involved, then it's IV. If vision is okay, then it's oral. That is it for question number 8. If you learned the difference between the polymyalgia rheumatica dose and giant cell arteritis dose today, hit that like button and subscribe to AMC Decoded. I'll see you in the next video.